Hi everyone, my name is Ariel Wolf. I'm from FAU. I'm going to be speaking about clean closing tables in colorectal surgery. In terms of disclosures, we do not have any relevant financial disclosures. A little bit of background, surgical site infections are the most common complication after any surgery, defined by the CDC as a surgical site infection within 30 days following surgery. It is about 10 to 30% in elective colorectal surgery versus 2 to 5% in all surgical procedures combined, which has initiated an SSI reduction bundle. This is an example of what we use at our institution. It includes preoperatively a mechanical bowel preparation with oral antibiotics, intraoperatively hair removal with clippers, and what this study specifically focuses on, a clean closing table consisting of replacing all instruments as well as all staff, rescrubbing, gowning, and gloving. In terms of methods, this was a single-center retrospective cohort study at a community hospital in Boca Raton. There was multiple surgeons involved, multiple general and colorectal. It was over the time period of about 2 years. ERAS protocol was utilized for all of our patients, and our cases consisted of a clean closing table being utilized, and our controls were no clean closing table, normal surgical procedure. We included all adult patients greater than 18 years of age with any colorectal pathology between these dates. Both open and robotic cases were included, and our exclusion criteria were patients less than 18 years of age, patients that did not have any data on clean closing tables, as well as any other incomplete data. Our primary outcome was the rate of surgical site infections during our index admission. Secondary outcomes included all other complications, length of stay, readmission rate, pain control, as well as other data that was collected. Our statistical analysis utilized EZR and R, chi-squared, and Fisher's exact tests were used for categorical variables. Student t-tests or Mann-Whitney tests were used for continuous variables, and a p-value less than 0.05 was considered statistically significant. In terms of results, we had 276 patients that met inclusion criteria. The majority were female. The average age was 68.69. Average BMI was 26.41. And the groups were clean closing table and non-clean closing table. In terms of our demographics, they were homogeneous throughout, apart from ASA status, as previously mentioned. There was significantly more ASA 3 and 4 patients in the clean closing table group. In terms of operative details, the only statistically significant results were that there was increased drain usage in the non-clean closing table group, as well as Foley's were more likely to be used as well. There was no statistical difference between infectious complications, specifically surgical site infections between the two groups. There was a statistically significant increase in post-op nausea or emesis in the clean closing table group, which we could only explain based on increased anesthesia time. However, the operative time was not statistically significant. It did trend toward increased time in the OR, obviously with a clean closing table group. So in conclusion, the use of a clean closing table does not seem to be an independent factor that reduces the rate of surgical site infections. There was no statistical significance in SSIs or other complications, but it's possible that the utilization of a clean closing table is more effective as part of a bundle, but we do need a larger sample size in order to evaluate which part of our bundle is most effective. These are my references. Thank you so much.